um, Hospice and Palliative Medicine Service. And David has been deeply involved with the Palliative Medicine Fellowship since co-founding it in 2009. And David just gave me permission over chat to share that he's retiring at the end of this academic year, which is amazing for him and also such mixed feelings for me. uh, he is a phenomenal educator and clinician and has taught so many of us here at UW Medicine and beyond. Any of you who have attended one of Dr. Gruenewald's talks knows that his presentations are superb. And a few weeks ago, Ashley Meager, the fellow, mentioned that he had given her a presentation on trauma-informed care that changed her practice. And I was thinking since then, like, how am I going to hear this from David before he retires? And when our grand round speaker had to cancel kind of last minute, and I asked David to step in with less than 24 hours notice, he graciously agreed to do so. Um, it's really hard to overstate my appreciation and gratitude for Dr. Gruenwald, and I'm really grateful that you're here today.
Well, thank you for that very kind introduction, and to all of you for attending. Just wanted to mention that this talk is the product of an interdisciplinary collaboration. So just to acknowledge my collaborators, and also just to say that really this talk was meant to be given by a team rather than by one member of a team. So uh, unavoidable under the circumstances, but wanted to acknowledge Dr. Hallie Newsom, our team psychologist here at the VA, Alice Foy, our palliative care nurse practitioner, Lauren Carpenter, a physician colleague, Chaplain Aaron McCardle, and also Shobha Stack, who is a former fellow, graduated from our Palliative Medicine Fellowship and is now practicing in the Seattle area. So many thanks to all of them. So a few objectives to mention. Really, we're going to talk about how to recognize trauma in our practices, but also more systemically, how to incorporate trauma-informed care into our systems of care. We may be able to identify clinical signs that suggest a history of trauma. Of course, we'll talk about the principles of trauma-informed care and then how to implement those principles specifically in an end-of-life care setting. This is an actual case that really prompted us to develop this talk, and we've changed a few of the details to protect the privacy of this patient. But a young woman with metastatic breast cancer diagnosed about a year prior, she had refused cancer-directed treatment and then presented to the hospital with severe cancer pain. She was also initially hypercalcemic. And she had come to us from elsewhere in the region to VA Puget Sound, and she was offered after admission palliative radiation for her cancer pain management, but she declined that, also declined many nursing cares, and she really didn't want to speak to providers. So shortly afterwards, she asked to be released from the hospital. She said she wanted to leave, despite initially wanting to come. But by then, her pain was so severe, she was pretty much immobilized and unable to discharge. So her background, this person was an Army veteran. She had had considerable educational attainment with higher degrees in criminal justice and security management, and despite that educational attainment, she was intermittently employed and had been also unsheltered at times. Unfortunately, she didn't have family support or other support in Seattle, even though her family were in the region. Past medical history notable for comorbid illnesses, diabetes, hyperlipidemia, a chronic pain history, and both tobacco use and alcohol use disorders. Mental health issues included post-traumatic stress disorder, for which she was service-connected. She had a history of both childhood trauma as well as military sexual trauma. And symptomatically, depression and anxiety in her history, and evident irritability and mood issues in our interactions with her. So moving from the case to just kind of talking about definitions and background, we really liked this definition from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. And they define trauma as individual, historical, intergenerational, or community-based trauma that results from an event, a series of events, or a set of circumstances, and that we experience as harmful, physically or emotionally harmful, or even life-threatening. And this experience has lasting adverse effects on our functioning and our well-being in multiple dimensions: mental, physical, social, emotional, and spiritual well-being. So it has these overarching effects on our life from that point forward. So we might conceptualize trauma in terms of these 3 E's: events that lead to experiences that lead to effects. And there are multiple types of events that can lead to a traumatic effect. Starting with abuse, maybe it's emotional or sexual, physical. It might be domestic violence, maybe even witnessing violence to others, bullying or institutional abuse of various types. Secondly, different kinds of loss events. It might be a death event or abandonment, neglect, separation as in a divorce, for example, and the childhood experience of parents divorcing. Maybe natural disasters or the experiences of terrorism or wartime. And then other types of chronic stress. They may be experiences of impoverishment or racism. In our world, experiencing invasive medical treatments. And then in the broader community, there may be traumas or historical traumas, things that were done to your ancestors, or a family experience of trauma, including, for example, substance use disorder. Then the experiences that emerge from these events will depend on each individual. So that person's experience is going to differ from other people's experiences. And that over time, chronic stressors can accumulate. And our reaction may be affected by our earlier experiences in life, some of which we might not even remember, such as experiences that we had or events that occurred in early childhood. Sometimes the events we deem necessary, for example, in the case of medical procedures, to try and sustain life. And there may be events that happen to a group that one closely identifies with. So, for example, if you were an indigenous person, a Native American person, for example, you may closely identify with the genocide of your people. And then these events and experiences can affect the way we cope with things that happen to us subsequently. They may affect our mastery of developmental tasks in childhood and in adult development. And then our experience of engaging in relationships and our ability to engage. We may hold people at arm's length if we've had a trauma. It can affect our physiological responses and our psychological well-being. It can lead to diseases, and I think we'll see this illustrated in the case as we talk about that at the end of the talk. Our spiritual beliefs may be affected. We may have been a person of faith, and we may lose our faith along the road based on our events and experiences. And our ability to trust in others, including the healthcare system and the providers who work within it. So we might start with this 3 E's model, but also conceptualize trauma in other ways. So we might think about, for example, the types of stress that we might experience. Some might be positive. Maybe we are anticipating starting a new job and we're looking forward to it, but yet it's still stressful. Other types of stress may be tolerable, but we can get through it. Maybe we've lost a job. Maybe someone that we love has died, and we're finding ways to navigate. And then there are toxic experiences of stress, domestic violence or military sexual trauma, or a family history of enslavement, or the cultural genocide experience of indigenous people. So what does this have to do with care at the end of life? I come from a veteran-centric care setting. And so what I will say is that trauma is extremely common in our population. So I'm going to kind of look at this through a veteran-centric lens, but I think as you reflect on your own experiences, you will find many, many examples in the care of people who are near the end of life. So as we think about what happens in the normal aging process, life review is a normal part of that process. And oftentimes as we age, we begin to integrate events that have happened to us. And some of those events are traumatic. And we find in the care of people near the end of life that during this life review process, symptoms might emerge, and we see this commonly in veterans with combat experience or other trauma experiences, that PTSD symptoms emerge commonly in these people. And there's a term for it that has been used called later, LATR, which stands for later adulthood trauma re-engagement. And this is something that has come from our understanding of the veteran experience in late life, as well as other late life experiences in non-veterans. But I alluded to how common it is for us to observe this kind of later adulthood trauma re-engagement in veterans. And just the evidence that it's common, 85% of veterans have experienced some kind of trauma during their lifetimes, much of this related to their experiences in service. And then as they near death, it's common for trauma-related memories to occur during this life review process and PTSD symptoms to emerge. And so these symptoms might include PTSD-like symptoms of intrusive memories, dreams and nightmares, flashbacks, or even dissociative experiences, and psychological distress more generally when reminded of the trauma or cues are experienced. And so this later adulthood trauma re-engagement, it really refers to that process where the person is trying to confront or rework these traumatic memories as they face the challenges of getting older and facing death in the foreseeable future. And it's characterized by a desire to bring some form of coherence to what has happened and to make meaning from it. And it's especially the case if these experiences have previously been avoided or if they remain unresolved. And it follows that the outcomes may be both positive or negative, depending on how things progress. And if we can influence this in a positive direction, we want to do that. If left unattended, there may be more distress, especially if those memories are painful or if they're unresolved. But we may find ways to facilitate post-traumatic growth and to support the person's attempt to derive meaning from these experiences and ultimately to have a greater life satisfaction at the end of life. One other point to mention is that in the setting of cognitive impairment from dementia or in the development of delirium, it's really common for this re-experiencing phenomenon to occur. So what now? How do we recognize trauma in our practices? I'm going to suggest 4 approaches that were suggested by CAPC, the Center to Advance Palliative Care. Oops, let's see what happened there. Let's say. So I really like this first option from CAPC. It's sort of like the universal precautions approach. And it invites us to assume that everybody that we encounter has had something, and to approach patients using this trauma-informed lens in which we understand that whatever adverse experience this person has had, it may contribute to the presentation. It may contribute to the way they cope and behave, and it may even contribute to the set of illnesses that they bring to their clinical encounter. But regardless, if we assume instead of inquiring at this point, we aren't depending on them to disclose. We can just offer the interventions that address whatever experiences they may have had and whatever consequences have ensued from that. The second approach, we're really good at opening the door to disclosure, and these things may emerge in the course of us taking a history, of us asking a few well-placed questions and then seeing what happens. And then the person can decide what they're going to talk about and what they're not going to talk about. We might say things like, difficult life experiences can affect our health. Maybe we have grown up in a family where there were drug and alcohol issues. Maybe we have witnessed violence within the home. And so I'm just wondering whether you have had any past experiences that you feel like are affecting your physical or emotional health today. And then you let that sit and see what comes back to you, and people can either decide to respond or let it pass or move on to something else. So that's another option that we have to explore the trauma history. This third option, to use a structured tool, there are a variety of choices available to us practitioners. This is one example, the Life Events Checklist, or LEC5. I have to say that in the type of conversations that I have with patients, I tend not to use tools like this, but there are certainly other professionals. Psychologists, for example, might use a tool like this, and if it works for you, then by all means. And then the fourth option, in my mind, this really dovetails well with the first option of just assuming a trauma history, but we can identify the impacts of the trauma instead of the trauma itself. And as I look at this list of common conditions that are highly correlated with traumatic experiences, it's like check, 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 check. I mean, most of my patients have one or often several of these problems. Anxiety or PTSD, or depression and a history of suicidality, or maybe even active suicidality, a substance use disorder history, chronic pain, and manifestations behaviorally of anger and aggressive behavior. So we can think of these as markers of a trauma history, and then this can propel us into using trauma-informed care. Other things we may see, these first several really make us think, PTSD, the hypervigilance or an exaggerated startle response, being sensitive to noise or not wanting to be touched, or being touched in certain ways. One thing that I have learned over the years is I never touch a sleeping veteran on their legs. I've seen it happen where somebody walked into a room and touched somebody on their legs, and the person just like jumps off the bed. So let's not do that. Let's take a different approach. Maybe we will knock, talk, and walk. We now have that posted in many settings to remind us of a more trauma-informed care approach. There may be intrusive memories or nightmares or difficulty concentrating, or even a person having difficulty discerning what is safe for them and what is dangerous. On the behavioral side, we may see examples of irritable or aggressive, or even risky or destructive behaviors. We may see a disproportionate response or even an explosive response when somebody is corrected. Maybe they say something that is manifestly false, and they're corrected, and they react in a disproportionate way. People who don't want things to change or very rigid in their thinking about what they're willing to accept, that might be a traumatic indicator. Difficulty trusting, including trusting the healthcare system, or exhibiting wide swings of emotion from one time to the next. So you kind of start getting the feeling that, man, I've seen every one of these things so many times. So what do we do with all of this? Maybe it's time for us to just kind of back up and think, maybe we can start working towards a different way of moving through the world, and ultimately maybe working sort of piece by piece to try and change the world we live in, so that we are now interacting with people in a way that assumes that we have all had something. We have all experienced hardship and struggle, and we're going to be with them and engage with them from that place of knowledge and understanding. So it's like, we're trying to walk a mile in their shoes. I mean, there are so many aphorisms that we might pull in to help us think in these terms, but this is really what we're trying to do. We are trying to develop a different approach. It's both a personal approach to our practices, and it's a systemic approach that assumes that everybody has something, and that everybody who encounters the system or works within the system may have had a significant trauma, and we all want to avoid re-traumatizing ourselves. And so just understanding that when people have experienced a trauma, it's going to change the way that we react. It's going to change the way we cope with things like pain and terminal illness and loss, all the stuff that we see on a daily basis in our work. And it's not only the patients and families, it's all of the people who work within the system. So it's everyone. So then, this is what we aspire to in our practices and as a system. These 4 R's, the trauma-informed practice and systems, abide by these 4 R's. So we realize the impact of trauma, and we understand people's actions and behaviors in the context of the strategies to cope that each of us have had to develop in order to manage and survive adverse circumstances, and often overwhelming circumstances. So now, all of this is not to say that we are justifying or excusing behaviors that are unacceptable, but it's important for us to understand and kind of have that point where we are bringing our understanding into why this is happening, and then we can choose how to respond accordingly. So then we recognize the signs and symptoms of trauma in everyone that is a part of this, patients, families, and those of us who work within the system. And we also recognize then the importance of workforce wellness so that we can continue to do the work that we want to do and provide the care that we really aspire to provide. And so it's easier to realize and recognize sometimes than it is to respond and change. But we have to ultimately be willing to change and change ourselves. And so that means taking the knowledge that we have and our understanding of how pervasive trauma is in our lives in 2025, and work on our policies, our procedures, and our personal practices, and ultimately advocate for systemic change when necessary. Then this last point of how we resist re-traumatization, what do we do in order to do that? So I'm going to present to you from the SAMHSA framework, these 6 principles of trauma-informed care. And so we want to incorporate each of these 6 principles into our individual practices and our organizational structures over time. And if we can do that, it's going to make a lot of difference to the survivors of trauma, but more globally, it's the right thing for us to do. So let's start with safety. And I think of safety as our goal is to create a safe container. And that's the term container sort of calls up to mind a physical container. And it does have a physical aspect of creating a physically safe space, but it's also a psychically and psychologically safe space for everybody to inhabit during this time. And I call to mind the experience of a homeless person, for example, where there is nothing safe about the space that people who are insecurely housed spend their lives in trying to anticipate the next thing that's going to happen to them in their physical space. So perhaps we create a respite from that in a physical space, but also in the way that we offer respect and support and kind of that whole nurse mnemonic that we do in our conversations. And all of the 6 principles of trauma-informed care that lead to the safe container that we're working to create. A few other tips: asking permission before we do things to people, and we'll say a little bit more about that. We're going to explain what we do and ask permission before we do things. The wound care is a good example. That's often a painful procedure. So before we begin, we say who we are, why we're here, what we intend to do, and we invite people to let us know how they're experiencing the care along the way. Just an example of, instead of doing things and telling people what we're going to do, we're asking first. And so the language that we use, we might say things like, what do you like to be called? And then we can use the preferred name before we begin our interview and care. And then the person who is delirious, we can use some of these trauma-informed care principles and the way we manage the environment. Managing the chaos that is common in hospitals, managing the noise levels, turning off the TV news or to something more soothing if we do have the television on, etc. There are many things that we can do in the environment. So moving to the next of the trauma-informed care principles, at each step I'm going to give a couple of examples and then I'll summarize some of those a little later. Trustworthiness and transparency is the second principle. So really we want to show that we are trustworthy. We don't assume from the get-go that we are trusted here. We are holding ourselves accountable to build trust and then to maintain that relationship of trust over whatever time we have with the person. And we must understand that the person themselves is the expert on themselves and what matters most to them and what their symptoms are and what's most distressing to them. And so we validate their expertise in these areas. When we are accountable to build and maintain trust, we must make promises carefully. If we offer a promise, we only make the promises that we're actually going to keep. So that's a part of the nurse mnemonic is support. And if we're offering support, just being mindful about what kind of support we're offering and whether we can actually deliver. Then being very mindful about past experience of betrayal of trust. And most of us have had some kind of experience of betrayal. Maybe it's from a parent or a teacher or a coach, a trusted caregiver, or maybe it's from a betrayal by a system. It may be healthcare, it may be military in the context of the veteran experience, or it may be the government or some other system. We might acknowledge this. And I was thinking about what kind of things I might say to acknowledge that history of broken trust. We might say something like, thank you for sharing that experience with me. It makes total sense to me why you would find it hard to put your trust in us now. And I hope that from this point forward, we can do a much better job of earning your trust. I mean, that's just an example of something that we might say that acknowledges and expresses the hope to do better in the future. And then, of course, they're going to be watching to see, well, how are you doing? I mean, those are nice words, but show me the meat in the language of the 1980s. Show me the meat, or where's the beef? What about peer support? We can't always offer a peer support network, but sometimes we can. And when we can, that can be an enormously helpful intervention. It can be a way to establish a self-help approach. It can help to establish safety and hope through peer support. It can build trust and confidence in the system of care, improve collaboration, and bring the whole range of lived experience in to promoting the goals of healthcare and healing. This is very important in veteran care, and veteran support groups really acknowledge that a lot of times veterans trust veterans more than they trust the healthcare system at large. So having veteran support groups is often a part of what we offer in VA care, in oncology care. Having access to a support group of other veterans with cancer is a great example of that. And if we can offer a referral to a peer group and have educational materials available, so much the better. And if we are ourselves within a support group, we can validate the experiences of others and use some of our language that is well known to us to support and validate and normalize the experience of others in the group. Collaboration and mutuality focuses really on changing the power dynamics within the relationship. When somebody walks into a hospital, that entails a power differential. They're on our turf. Let's see, I think I just, sorry about that. It changes the power dynamics just to walk into a hospital. Now they're on the turf of the healthcare system. And I've learned a couple of things from talking with people who provide home care. And home care providers are stepping onto the home turf of the patients and their families, and the power dynamic is very different there. And maybe we can learn something from that and learn to level the power dynamic when people step into a hospital or clinic environment. And we should really take steps to have our patients and families be equal partners. In the large volume of caregiver literature, it's really clear that a lot of times we fail to include caregivers, informal caregivers, as full partners in the care planning process. And that's really a problem. It's a problem that we can address and use that in establishing trauma-informed care. We find out how to make people more comfortable during their visits by asking. And then, as mentioned, we explain what we're going to be doing and ask permission before we do it. We empower people. We bring their voices forward and offer choices. In all major aspects of care, so it's a shared decision-making process in which we suggest choices, and it's a shared goal-setting process. That really sounds like what we do in our routine palliative care and hospice work, but it's good to think about this in a very global way and to respect and honor the decisions that patients make, even if we disagree, and Also to listen carefully to what choices they are making and offer choices when possible about how care is given, when and where. And again, ask permission. We want to facilitate healing of the individual. We don't want to control the healing process. And so asking permission at each important stage, including who should be included in the decision-making process. All of these things help to build and maintain trust. And then we get to cultural and historical and gender issues. And so we are trying to move past historical stereotypes, cultural stereotypes, and the biases that each of us carry with us. We need to recognize the pervasiveness of historical traumas, racial, ethnic, and cultural experiences that patients, providers, and staff and families all have and bring to our experiences. And the notion of our own stimulus value. Now, I want us to think about just an example of this. How often have you seen care in an inpatient setting? We walk into a room, there are multiple providers that meet with a patient, and every provider in the room is a white person, and the patient in the bed is a person of color. So if we think about that, and we think about how this might affect the person's experience of care, what can we do as individuals on the provider side, on the healthcare side, to mitigate the possibility that we might actually trigger a response? So we might have done a chart review, and we might understand that this is a person that doesn't really trust the healthcare system. And we might use an example of language that acknowledges that, such as the example I mentioned a few minutes ago. Just to acknowledge it's totally understandable that you experience us in this way, and we're going to do everything we can to include you as a full participant and to listen carefully and hold us accountable. And then the other part of this is that because we bring our own trauma history in, we might reflect on that. And maybe we think about that outside the room, but we may actually find that we understand the person's experience because we ourselves have experienced something similar. And this may help us to bring transference and countertransference into our professional relationship in ways that help us develop a deeper connection. So it can be a positive thing that helps us really to give better care ultimately. So by keeping these 6 principles in mind, we can avoid re-traumatization, and overall is just the right thing to do. So this is just another way of looking at some of the interventions that we've talked about, many of these, and this is kind of inpatient focused, but you can imagine outpatient or even home care directed approaches that might mirror some of these. Environmental changes. And I think about this list as really being appropriate to pretty much every delirious patient as well. Orientation devices such as clocks and calendars and whiteboards that have the name of the unit and the providers, using a night light, sort of managing the amount of stimulus in the environment with minimal noise, but not sensory deprivation either. A relaxed environment of care, and providing items that the person needs within reach of the person. And then there are relational issues that we've also talked about some of these. Knock, walk, or knock, talk, and walk in that order. So we announce ourselves, we explain who we are, why we're here, and if there are any procedures that we're planning on doing, asking permission before we proceed. We hold ourselves accountable to build and maintain trust. We are calm even when the other person is not calm, and we are sort of pacing the other person in a way and controlling our own breathing and our own way of being together, and in training and attuning ourselves to the other person. We are asking instead of telling people. We are using that shared decision-making approach, and we are focusing on the other person's comfort and checking in from time to time to see how people's comfort is doing. We are being mindful about possible triggers, such as wearing the white coat and being a bunch of white people in the room with a person of color. We are respectful and we listen, as we do in our work. And we avoid generalizations, and we ask instead of assuming. So now back to the case. This is a young person with breast cancer, recently diagnosed, relatively speaking, who has declined cancer-directed therapies. I've highlighted a few sections here that to me illustrate, this person sounds like probably a significant trauma history. The cancer pain and hypercalcemia and coming into outside the region, declining multiple interventions that were offered, including things that we felt certain would be helpful for the person's pain, and having initially wanted to come to us for care, now wanting to leave, but being unable to actually leave because of the severity of pain and immobilization that resulted. So I was the provider on this palliative care consultation, and this patient had a very strong reaction to my knocking, talking, and walking as I came into the room. So this was a person who, despite the pain that she was experiencing, actually came up off the bed and looked alarmed when I came into the room. So I apologized and backed away. And then we huddled for, how are we going to support this person? So there was evidence here of destructive behaviors, irritability bordering on, wow, this is like 4+ PTSD type behavior, resisting change, and difficulty trusting. And there were additional manifestations of those things as we got to know this patient. The social history suggested more, just knowing how common trauma experiences are in veterans. And despite the educational attainment, seeing that intermittent employment and housing insecurity were a part of the picture, and lack of social support, these are chronic, toxic stressors. And then we see also in the events, this person has had an early cancer diagnosis in young adulthood, childhood trauma, and military sexual trauma. So those are pretty significant events that through her experiences have then contributed to multiple significant effects, traumatic effects, housing insecurity, job insecurity, PTSD, and symptoms, depression, anxiety, and mood issues. And altogether, these multiple past traumas have put her at high risk of chronic disease. And those are evident in the past medical history that we see here. Let's see. So our psychologist evaluated the case and recommended no male providers. So there was a safety issue for the patient, and gender issues were present. We wanted to limit the contact to one female provider and to keep that person engaged for longer than usual to build trust over time and to be transparent. And then we were able to build a cohort of female nurses with time to get to know one another and some tips and tricks to support the person and improve distress tolerance, ice packs, deep breathing, other interventions to support collaboration and mutuality. So a couple of weeks later, after this trust building began, she agreed to work with our psychologist. She was afraid to take pain medication, and we recognized that as being related to her experience of loss of power, voice, and choice that was experienced in her prior traumas. And then it took 1 month of working with a psychologist to build post-traumatic growth. She agreed to meet with our team chaplain to expand the network of psychosocial support and meet with the palliative care nurse to talk about hospice care. So collaboration and mutuality took time to develop. Then ultimately, she built strong relationships with nearly everybody on the team, and with multiple team members, her communication became less volatile. The team was distressed, and we haven't focused much on the team experience, but this was really hard for all of the team members who were involved. But ultimately, we better understood her perspective and what we could do to interact more effectively. And as a result, she ultimately accepted a male nurse and a male physician as part of her team. She accepted pain medication, and she died peacefully and comfortably on the inpatient unit. And then as we move to a close, we all need trauma-informed care too. At the VA, we've established a couple of kinds of staff support rounds and different venues for staff support, including for staff in crisis. There's an employee assistance program available in most systems of care, employee home health, chaplain support, and in the UW system, peer-to-peer support, and ultimately giving each other grace, because ultimately, we are all in the same boat. We're all struggling in some way. So a lot of veterans have experienced trauma. All of us have experienced trauma. Sometimes trauma symptoms reemerge at end of life, and we can respond in ways that avoid re-traumatizing people. So I just invite you to think about how you will incorporate principles of trauma-informed care into your